So we move on to the next session. So next I call upon Dr. C. Anjalakshi and Dr. E. Suresh to take over the next session. On to you, sir. You can introduce the speaker.
First, I would like to thank the organizers for giving this opportunity. I'm Dr. Suresh from Stanley.
Good afternoon, everyone. At the outset, I would like to thank Professor Seshaya and Dr. Shanmugam and the other organizing team for giving me this opportunity. In this session, we are having 3 talks. The first one is by Dr. Nandita Arun in the Transforming Diabetes Care with Second Generation Basal Insulin. We have the new basal insulin added to the insulin armamentarium, and she is going to talk on that.
Thank you, madam. Very good evening, and it's a pleasure to be here this evening. Thanks to the organizers for having me here, part of DAISICON2025. Is my voice clear? I feel pretty highly placed in quotes at the back of this. The voice is audible till the back? Great, thank you. So I'm here today to discuss, as the chairperson had just introduced, the second generation basal insulins and how, where and when they fit into our daily clinical practice. This is the flow of my talk. So before I move on to the actual molecule and what we're here to discuss today, just to set the context, we know that there is a growing burden of type 2 diabetes, type 1 of course also, but there is a growing burden of diabetes or dysglycemia in our part of the world. And at the same time, there is also a growth not just in the burden of diabetes, but also a growth in the treatment modalities. So it's probably best also, like Ashirvadam sir was just saying at the end of his talk, it is evolving so rapidly that this is the best era for us to probably be practicing diabetology, because we are now equipped as clinicians with n number of agents that address multiple pathophysiological features. So we've moved beyond the beta cells. Earlier we used to believe that type 2 diabetes was restricted to the beta cells, beta cell dysfunction and beta cell or insulin resistance on the other side. But now we have come to realize that management of dysglycemia in type 2 diabetes is beyond that. It is beyond the beta cells. It encompasses a lot more pathophysiological features, and we also have agents to address these features as well. However, that being said, in spite of these multiple agents that we have today, insulin still remains the kingpin, right? We cannot dismiss the importance of insulin. Now, although we have insulins on one side and the evolution of insulins itself has evolved over the years, and we have these multiple agents, the sad reality, and that is what the slide here today is showing us, is that the sad reality is that in spite of this evolution of drugs, we still have an average HbA1c of around 9%. And that is what the data here, this is a pan-Indian data looking at around 382 sites all over India, and the average HbA1c of a patient with type 2 diabetes is still around 8 to 9%. So why is this so? What is the factor that is actually contributing to this uncontrolled diabetes? Why is it that in spite of having so many agents and in spite of having these evolved agents that we have, why with so many tools are we unable to achieve targets? Quite often we, as clinicians and even patients sitting at the other side of the table, imagine that once insulin is initiated, the job is done, right? So quite often when we have the patient, we start the insulin and they say come back after 3 months, assuming that next after 3 months when the patient comes back, the blood sugar, and the patient also believes that the job is done, that they're taking insulin and their sugar is going to be under control 3 months down the line, magically the HbA1c. But it is not the case, because it is not just about initiating insulin, but extremely important to titrate insulin doses to achieve those targets. And that titration period is especially crucial in the first 8 to 12 weeks of insulin initiation. This is the golden period during which dose titration to achieve the ideal target, setting our targets and reaching these targets is extremely important to in turn reach that target HbA1c that we would like to at the end of 3 months. However, there are a lot of barriers, isn't it? And this is a very commonly presented slide. We all know that there are barriers not just on the patient side, but we as clinicians are also equally guilty of delaying insulin initiation, of the clinical inertia of insulin titration and achieving targets. We are also equally guilty of delaying insulin intensification. All this is because of many factors put together, various misconceptions that patients have, various fears that patients have. The most common though, when you see both the circles that sort of overlap, the common factor that actually acts as a barrier is topmost is the fear of hypoglycemia. The fear of hypoglycemia is not just for patients, because as we know, if a patient experiences one episode of hypoglycemia, not just the patient, but if their grandfather or their father or uncle experiences, anybody in the family that they see with one episode of hypoglycemia, once bitten, twice shy, they literally are in fear after that, right? And then when we tell them to intensify their doses, the patient is always fearsome. Similarly, we as clinicians also do not want our fingers burned. How many of us want our patients calling us up at 2 a.m. saying, "Doctor, my blood sugar is 50, right? So, and that is a nightmare, not just for the patient, but also for the doctor. So, we want agents that will achieve targets without that fear of hypoglycemia, which then brings us to that balance, a very delicate balance that we do have today with the newer generation insulin. So, as I mentioned earlier, the anti-diabetic agents have evolved over the years. We have multiple agents that target multiple pathophysiological features, but that being said, insulins have also evolved. Right from Banting and Best and the discovery of the initial porcine insulins to the bovine insulins, and then now we have the human insulins, and amongst the human insulins we have the analogs, which have also evolved. Down the line we also have probably once a week insulins, but today what we have available are insulins that have made it realistic to achieve targets in our patients without the risk of hypoglycemia and many other benefits that these insulins actually offer. So, what would be those tick marks? What we are seeing on the right over there is what would be the ideal insulin that we want. Topmost, of course, we want an insulin that is, of course, at the end of the day, we want a reduction in blood glucose, right? So, we want an insulin that will help us achieve that target fasting plasma glucose and postprandial glucose and HbA1c. But that being said, we want an insulin that reduces the risk of hypoglycemia, reduces glycemic variability, reduces the burden on the patient with minimizing complex regimes, improving patient compliance, and we want flexibility with dosing as well. So, all these together is what we have today in our second generation insulins. So, what we are discussing now is Glargine U300, which is the brand name is Toujeo, and here we have data showing us that Toujeo is a molecule, or Glargine U300 is a molecule that has been, as a formulation rather, that has been widely studied. It has been extensively studied in comparison with the previous second generation insulins, and what we have here is the addition trials or the addition programs which are in comparison with Glargine U100, and we have in comparison with Degludec, we have the BRIGHT studies, we have OneCare and a whole lot of PKPD trials. I'm going to quickly run through a couple of them just to sort of throw light on the actual benefits of the formulation. So here we have an RCT, these are the addition programs. There's addition, a whole range of them, which is addition 1, 2, 3, 4, JP, which is in the Japanese. But overall, the addition trials are a comparison between Glargine U300 and Glargine U100. And this is these are RCTs in a 1:1 ratio, in which participants were randomized into two groups. One group was on Glargine U300 and the other was on Glargine 100. At the end of the trials, as a whole, we are looking at the plot over here that is showing us that the overall risk of hypoglycemia, both nocturnal and anytime hypoglycemia, was overall much lower. I don't think this pointer, anyway, yeah, it was much lower in the, yeah, I think that works. In the Glargine U300 arm, as you can see on the left, everything that you're seeing, addition 1 to addition JP2, and in patients with type 1 diabetes as well, overall nocturnal hypoglycemia as well as anytime, any day hypoglycemia was lower in the Glargine U300 arm as compared to Glargine 100. Now, we saw that hypoglycemia risk was much lower. But what about the A1C? I think we'll wait for sir to be seated. Hello, sir. An honor to have you. Right. So, although there was a reduction in the risk of hypoglycemia, was that at the cost of achieving targets? Not so. So, as we can see, the HbA1c, as you can see the green and the purple bars that you're seeing, there was almost similar HbA1c reduction, probably slightly lower with glargine U300, which was sustained over a period. And this was with a lower, so you're able to achieve a lower HbA1c with a lower risk of hypoglycemia and in turn lesser weight gain with glargine U300 as compared to glargine 100. The next group of studies are called the BRIGHT studies. These BRIGHT trials are comparing, this is a more fair comparison because we're comparing two molecules or two formulations that are pretty similar to each other. That is glargine U300 on one hand and degludec on the other. So this is called the BRIGHT. This is again a 1:1 RCT in which you have glargine U300 versus degludec 100. At the end of the BRIGHT studies also, they found similar HbA1c reduction over a period of 24 weeks. As you can see, 8.7 versus 8.6 from baseline with degludec versus glargine U100. However, although the HbA1c reduction was similar, the overall hypoglycemia risk was lower in the BRIGHT studies conducted by Sanofi in glargine U300 arm as compared to degludec. As you can see, the overall hypoglycemia as well as nocturnal hypoglycemia was lower with glargine U300. More importantly, if you can see the graph on the left, we are seeing that the profile of the insulin peak is a little more with the degludec, is not as flat as compared to the glargine U300, and this in turn translates to a lower intraday glycemic variability as you're seeing in the graph on the right. The glargine U300 has a flatter profile and lesser glycemic variability as compared to degludec. The last trial is the ATOS trial, which is basically to look at patient satisfaction, and here we're looking at post hoc analysis in which those subjects who were put on glargine U300 expressed a much better improvement in quality of life, lower perceived frequency of hypo and hyperglycemia. So now that we've set the context of the advantages of these second generation basal insulin, namely U300 glargine, we're now looking at some practical tips. This is the last few minutes of my presentation. So what would be the initiation dose? Similar to the second generation basal insulins, it would be around 0.2 units per kg body weight. The preferred timing of the day would be obviously just once a day. Any time of the day, generally we tend to give it at bedtime, but it can be given any time of the day, plus or minus to be taken within that 3-hour window. So if the patient takes it at around 10 p.m., they should take it between the period of say around 7 p.m. to around 12 or 1 a.m. So they have the 3-hour window for them to take the injection. When initiating, it can be, because it's basically another second generation insulin, it can be combined with any of the other oral agents or any of the other anti-diabetic agents. The maximum dose for titration or intensification would be up to 0.5 unit per kg per day. So that would mean that beyond that, we would probably have to switch to another formulation or look for other possibilities, other agents to be added. And what is the advantage at the end of it of a glargine U300 over the 100 is that you get an insulin which has a flat profile, 24 or even beyond 24-hour acting, lower glycemic variability, lower risk of overall hypoglycemia and nocturnal hypoglycemia, and at the end of it you have also lower risk of weight gain as compared to the other insulins. This is how the device looks. You have a very sophisticated, very user-friendly pen, and you also have the permanent pen for refills. The formulation of course has 300 units per ml of glargine U300, which is why it's U300. The capacity is around 450 units. You can dial up to 80 units, but I'm sure we don't give that high doses. And the plunger is also very, very smooth, which is what it shows. The dial extension is very short and the holding time is around 5 seconds. So to summarize, today our management of type 2 diabetes has evolved, and in spite of the fact that we have so many agents, we are still under-treating our patients. We as clinicians need to wake up to the fact that we do need to timely initiate insulin. effective titration and intensification to achieve targets in our patients. Many of the barriers that we believed used to exist with the older insulins have now been sort of broken with these newer insulins that we have here today, and the U300 is one such formulation which provides a very flat profile, which is 24-hour acting or beyond 24-hour acting, can be given once a day with flexibility of timing, lower risk of hypoglycemia, especially nocturnal, and least glycemic variability, thus to improve outcomes in patients with diabetes. Thank you.
Thank you, Dr. Niveda. That was a wonderful deliberation. Actually, clearly you have narrated the barriers with the older insulin and the advantage of the newer molecule. Thank you. We'll have the questions at the end.
Now, I request Dr. Prabhu, who is one of a few experts in the field of nuclear medicine. Over to you, sir.
Thank you, chairpersons, for the introduction. At the outset, I would like to convey my humble pronounce to Dr. Sheshaya sir, my mentor, Dr. Shanmugam sir, Dr. Sundaram sir, and Dr. B. Shanmugam, Dr. Anand Masas, Dr. Vijay Kumar, and all my friends who have brought me here. For the next few minutes, I'd like to share what is happening, what could be the future of nuclear medicine, and how it has a big role in diabetes management. In fact, it helps a lot in early detection of coronary artery disease, especially when in asymptomatic patients. We know that these patients, we have a strong suspicion, and how to prove it, how to make his quality of life better, that's where we step in. And how to identify them over the next few minutes we'll be able to see. Before proceeding further, I take this opportunity to invite you all for our upcoming Asia-Oceania Congress, which is perhaps the historic Congress in India. This is being hosted by the Society of Nuclear Medicine India, which has about 3,000 life members, and presently I am heading it as the national president. And almost we have got 380 international delegates and faculty, almost 70 national faculties, national presidents are going to attend this event and join us with us in ITC Grand Chola. Speaking of coronary artery disease, it all independently matters to how the ventricle is contracting. Taking the long axis view, we can see how the ventricle is contracting, the various epicardial arteries, and this is what we see here, and we have to go, and there are certain parameters that determines the contraction. It can be elasticity, stiffness, compliance, viscosity of the flow, damping, so many other complex physics are involved to ensure that there's a smooth contractile process that is happening. But then if you dive deeper, today morning, Professor Arul Raj thundered that diabetes is a vascular disease. And what happens is there is hyperglycemic environment which causes increasing insulin resistance, and speaker after speaker they alluded how it is important. It affects the reactive oxygen species, affects the mitochondrial function, apoptosis, and this causes diastolic dysfunction of the heart, decreased angiogenesis, decreased coronary density, capillary density, impact vascular dilatation, then it causes systolic dysfunction. If you dive deeper, what you are able to see, these are the various pathways, the substrates, how they are being utilized. One, the pathways to the energy enters into the myocardium, cardiac myocytes, and in diabetes, there are a lot of structural and functional abnormalities, and which causes progression into the heart failure over a period of time, and that is induced by the reactive oxygen species and the mitochondrial dysfunction. There is advanced glycation in products, there is accumulation of dysregulated products, and there is glucotoxicity. Still go further, and this is how the energy metabolism acts. What happens previously, it is from the carbohydrates, and it enters into the circulation, and this is how the ATP is produced, and the chemical energy is converted to contractile energy. For understanding this, we should have a bit of understanding about the biochemistry and physiology that goes into the contraction of the heart. and all the conventional angiographic methods stops with here and at the level of microvasculature. Whereas in nuclear medicine, we go up to still at the cellular level. And what happens is, this myocardium is very intelligent. Normally, it uses fatty acids for its metabolism. Why fatty acids? When the oxygen availability is surplus, it produces more amount of ATP per mole of oxygen that is being burnt for its metabolism. On the other hand, when the myocardium is ischemic, it switches over to glucose metabolism because the oxygen availability is less. With whatever limited amount of oxygen that is available, it can produce more amount of ATP. Almost per mole of oxygen consumed, it produces 30 ATP, almost 2.58 ATPs per mole of oxygen consumed. And that is how it tries to maintain its viability by producing more amount of ATP. And dysfunction in this, it happens in hypertension, diabetes, MI, obesity, and also we have to appreciate, somebody was talking about brain-heart-kidney axis. All this dysfunction myocardium, it communicates through macromolecules, microspheres, so many other molecules. It keeps communicating with other organs, and eventually it will lead to failure of the organs also over a period of time. This is what exactly happens in the pancreas. When there is in the normal beta cell, there is influx of glucose into the cell due to the action of glucokinase, and we have seen the whole lot of things that was discussed elaborately earlier. And this pyruvate enzyme acts here, and there is increased ATP production, and this is how the insulin gets released into the circulation. Coming to the diabetes, there is increased glucose infusion because of the glucokinase activity, and the glycogen storage is increased to a level of glucotoxicity, and this enzyme doesn't act. GAPD1, this doesn't act, and pyruvate doesn't act. All these cycles get disrupted, and then gene expression happens, and this gene down-regulates the insulin secretion into the cell, into the circulation. As a consequence, we know what it is. There are other disturbances do happen in the energy metabolism due to various myocardial pathologies. Of course, LVH, where dysfunction happens at the level of Krebs cycle. In heart failure, it is because of the respiratory chain of enzymes. In various cardiomyopathies associated with diabetes, we have seen that it's the glucose transport that is impaired. And dilated cardiomyopathies is glucose oxidation cells, enzymes. There is ischemic syndromes, fatty acid transport that is impaired. In ischemia reperfusion, creatine kinase system gets affected, and in myocardial infarction, the fatty acid oxidation affected. So we are able to appreciate it is because of the dysfunctional mitochondria. In myocardial perfusion imaging, what we do is we use a tracer that goes into the mitochondria. When the mitochondria, that's where it is, we use a tracer called a system in your day-to-day practice that is preferentially taken up only into the mitochondria. Once it goes inside, it gets locked up into the mitochondria, it cannot diffuse out. And what we see here, this is how the enzyme, this is a raw unprocessed image of the myocardial perfusion imaging looks like. And we do use other fatty acids with which we'll be able to visualize the fatty acid metabolism, and also the neuroendocrine metabolism by using meta-iodobenzene guanidine for cardiac resynchronization therapies and all. This is a story of a 38-year-old man who walked into the Omandura multi-super specialty hospital telling that he just had breathlessness. He's a diabetic, and he had MI previously, but there is unexplained dyspnea even on minimal exertion. When we did a myocardial perfusion study, what we do is we use adenosine to give stress to the heart to the maximum possible extent. When we process the study, what we see here, the EF is decreased, the contraction function is decreased, the end-diastolic volume, systolic volume, everything is increased, the large ventricle is dilated, and this is the normal myocardium in the circumflex artery territory. To just to catch up, in the 12 o'clock region is the left anterior descending artery territory, and this is 12 o'clock to almost to 7 o'clock. From 8 o'clock to almost up to 5 o'clock position, that is covered by the right coronary artery. From 5 o'clock to 12 o'clock position is the circumflex artery territory. Just by looking at it, what we can just by looking, we need not remember the complex geometry of the coronary circulation. Just by looking at the images, we know what it is. And here we can see in the apex, there is a considerable amount of dead myocardium is there, and that is what able to appreciate when the patient is asymptomatic. What we do is, we do label the red blood cells with technetium pertechnetate, and we can see the ventricular contraction. This is called as radionuclide ventriculography. We can not only see the global left ventricular ejection fraction, and also regional contractile variations, where in the septum, in the lateral wall, how it is. And this helps us to understand the global ventricular function, regional wall motion abnormalities, how will the patient respond to stress and other interventions. We can also appreciate the systolic as well as diastolic dysfunction. The other thing what we routinely do is the misfold proteins called as amyloid proteins imaging, which we routinely do. Everything is available free of cost, covered under CM health insurance and the government multi-super specialty hospital. It is available for the poor patients. And we do what is called as pyrophosphate scan that helps us to identify whether any amyloid protein distribution is there. Whenever a asymptomatic diabetic patient is walking into a clinic, we should also appreciate it is more common in the male gender. And the body mass index is somewhere around 30. And in one of the studies, it was found out that about 81% of them are because of type 2 diabetes. Hypertension was there in 71%, hyperlipidemia was there in 52%, smoking history was there in 57%, that premature CAD was there in 26%, peripheral artery disease was in 31%, patient who had already been on insulin use with 48%, oral anti-diabetic patients were in about 37, ACERBs was there in 35%, statins were used, beta blockers were used. And when another study which compared the diabetic with non-diabetic uptake, what the myocardium uses for substrate, it was found out that the diabetic patients use more of ketone bodies. The heart we call as the omnivorous. It eats everything. It has to keep on continuously beating. It starts with the fatty acids, uses glucose, proteins, enzymes, ketones, everything it keeps continuously burning so that it keeps on continuously producing ATP molecules. And these are the various substrates, acetate, butyrate, total ketone pyruvate, and lactate, glucose and all. So in a normal and ischemic myocardium, it is more of glucose utilization what we can see here, unlike the diabetic patients here. Whereas when the patient is a diabetic, it is switches over to ketone body metabolism. And that is where the dysfunction happens. These are the tools we use to operate on the molecules at the level of DNA. What we use nowadays is called now the theme is on the personalized therapy. So I thought I'd like to touch upon what we do here in personalized therapy, what we are going to do in the future. We use what routinely we use in alpha and beta emitting radionuclides. That alpha emitting radionuclides use high amount of energy, it causes double stranded breaks. Beta nucleides cause about single stranded breaks, and OZ electrons causes the linkages that will be affected. And we use monoclonal antibodies. These bodies are about 10 nanometers in size. There are a lot of, we use DARPins and all. We target with a radionuclide. It goes into the target cells. It enters the nucleus. It destroys the DNA by various methods. And these are the common radionuclides which we are using for theranostics. And in the upcoming conference, we can meet and shake hands with all the original workers who are using this for their day-to-day clinical practice. Why we are particular that it should be less than 10 nanometers is because the nuclear pore, that is what it is about 40 nanometers in diabetes. And whatever the monoclonal antibody which we are using for cancer therapy these days, it's about 150 nanometers. So it is not able to enter into the nucleus and destroy the DNA. As a consequence, we have so many other side effects. Whereas when you are able to enter into the DNA and just resect out the areas which will cause dysregulation of the mitochondria, and we have a cure for diabetes depending upon the person. That is one such target. There are so many other cells in the heart, the pacemaker cells, the LV cardiac myocytes, endothelial cells. Endothelial cells are more in number. The vascular smooth muscle cells, lymphocytic cells, telocytes, pericytes, mast cells. And these are the cells which keep communicating with themselves and among the other cells of the body. And these are the potential targets that are going to come in future. So there was a study done in 2009 and which called as a detection of ischemia in asymptomatic diabetics, DIAR study. And in the DIAR study, it was found out that the person they were able to pick out large perfusion effects, non-perfusion abnormalities, moderate to large perfusion abnormalities in about 33 patients, and small perfusion abnormalities about 250 patients. These are the data which you are able to pick up. Ultimately, it says that it is very helpful if you are able to find out the patients who are asymptomatic, on whom we have a strong clinical suspicion when they walk in with the clinical symptoms what we saw earlier, and it helps us the quality of life, improving the quality of life. I was able to narrow down about 5 or 6 studies that were helpful, and it was found out that when you are able to identify the patients who are having coronary artery disease, the quality of life definitely significantly improves with appropriate treatment, especially with the newer imaging and newer theranostic therapy agents. This is the study, this is the latest, the Bradot trial that was published few months ago, a couple of months ago, in which the SPECT-MPI was found to be extremely helpful in identifying the asymptomatic patients, and these patients are followed up for a period of 10 years, or on average about 11 years, and over a period of time, it was found out it was definitely helpful. You can see the mortality and morbidity is slightly better than the patients who are not undergone the screening, and the MACE was definitely less than the patients who are not undergone the screening procedures. To sum up, one need not always be dependent on the SPECT-CT because it is not available in every center. At least we will use some form of equipment, some device, some strategy to evaluate the cardiac function. Maybe resting or stress ECG, if a myocardial perfusion SPECT or a PECT, if you are working in a tertiary care institution, we can use stress echo. The CAC score was discussed earlier. Multi-row computed CT can be done. Cardiac MRI. All these things are available to follow up over a period of time. All the type 2 diabetes patients. So when comparing everything, the myocardial perfusion study is one of the cheapest and the easiest, more objective, it can be easily reproducible method that will be helpful for us to identify, study the patients for a period of time. And a normal myocardial perfusion study in a diabetic patient who is asymptomatic or symptomatic, it indicates that for the next 2 years at least he will not be having any coronary event. And there is a strong clinical evidence that says that routine screening is very important. It definitely improves the quality of life. And once again, I'd like to thank you and humbly invite you for being a part of this very historic conference that is going to happen in India. And thank you very much.
Thank you, sir, for your in-depth talk. We'll have the questions at the end. Thank you.
Thank you.
Next, I call upon Dr. Bhavadharani. I think all of you know about Dr. Bhavadharani. She is an enterprising diabetologist. She is going to talk to us on metformin and beyond, the role of oral agents in pregnancy diabetes. Metformin, though all the academic bodies, they recommend in pregnancy from conception to confinement, still there is a lot of debate and controversy on that. So I think Bhavadharani will be able to clarify. Thank you, Bhavadharani.
Thank you, madam. Very good afternoon, one and all. My first pranams to my teacher, mentor, Professor Dr. Seshaya, and I thanks immensely the entire organizing committee for giving me this wonderful opportunity. First and foremost, why oral drugs in pregnancy? If you take type 2 diabetes and GDM, both we have insulin resistance and secretion abnormalities, and there is loss of first phase insulin secretion, and there is a striking lag time between the postprandial rise in glucose and also the presence of significant insulin resistance at the peripheral sites. So it's reasonable to assume that treatment of GDM with oral drugs should also be effective. And whatever oral drug you may select, it should not cause any hypoglycemia in the mother, and it should cater the insulin resistance, should not cross the placenta, as it can cause hypoglycemia in the fetus, and should not stimulate the fetal pancreas, causing hyperinsulinemia, macrosomia, and all other non-communicable diseases in the future. There should not be any teratogenic effect, and in our country, it should be able to tackle the postprandial hypoglycemia. Of course, in a randomized study, they found that 80% of the patients treated with oral agents, they were able to bring down the blood sugar well below 150 compared to only 38% with insulin. This is mainly because of the poor compliance. So oral drugs have been investigated as an alternative to insulin therapy because of their ease of use, compliance, and lower cost. And what oral medications is used for diabetes during pregnancy? Of course, insulin is the gold standard for treatment of hypoglycemia in pregnancy. But recent studies suggested that certain hypoglycemic agents, that is metformin, glyburide, and acarbose, may be safe and acceptable alternatives. And whereas if you diagnose GDM very early, it is we need a more aggressive treatment approach. Potentially, it should be only insulin. And for these with the those with the higher blood sugars also need insulin. If you take the molecular weight of oral drugs, all are well below 500. Whichever is below 500, it will cross the placenta, except for insulin, which are all very high, which will not cross the placenta. And if you take the layers of placenta in mice and rats, we have epitheliochorial, which is least invasive, and in rabbit you have the endotheliocrolial, which is partially invasive, whereas if you take in human, it is hemochorial. It's the most invasive and allows the fetal tissues to be directly bathed in the mother's thing. And if you take metformin, it has a small molecular weight, readily crosses the placenta. Half the plasma concentration is in the mother's fetus, like the mother. And if you take metformin, we have a historical use. It has been used in pregnancy since 1970 in South Africa, and it was initially preferred over insulin due to its lower cost, ease of administration, and its use became widespread in all the lower economic countries. And if you take the embryogenesis, well below 8 weeks of pregnancy, the total embryogenesis is complete. And of course, we come to know about confirmation of pregnancy and start using these drugs only after 8 weeks, so there won't be any problem. And if you take metformin with the rising rates of obesity and GDM, we need a cheap, acceptable and effective treatment for hyperglycemia. And metformin is useful, as madam said, from pre-conception to postpartum period, and it has been used in pregnancy for reducing the weight gain, also potential decrease in pre-eclampsia, preterm delivery and type 2 diabetes in future. And it's very useful in those with BMI more than 30. And even if you take the diabetes prevention program, they had a pre-specified subset of population with previous GDM, and here metformin reduced the progression to type 2, and this was significantly more effective in those with previous GDM compared to those without. And those who required insulin were heavier at baseline, and metformin therapy improved the weight loss in the postpartum. It's very important to maintain the weight postpartum. And if you take the molecular and cellular benefits, it has got anti-inflammatory action, lowering the levels of CRP and other inflammatory cytokines in the placental and other tissues, and it has got an angiogenesis modulation, decreasing the release of anti-angiogenesis factors from placenta and umbilical vein tissues, potentially promoting healthier vascular environment. Mitochondrial respiration, it can reduce the mitochondrial ATP production in trophoblast by affecting the complex 1 supported oxygen consumption, which could impact the fetal growth support. And it has epigenetic effects that it can reverse altered epigenetic markers like histone modification in placenta and diabetic mothers, which is associated with the altered biogenesis. And coming to the nutrient transport, this influences the placental expression of various nutrient transporters, potentially affecting the transfer of nutrients, that is all nutrients, glucose, amino acids, fatty acids and vitamins, all from mother to placenta. And if metformin, regarding metformin exposure in the very first trimester, remember the embryos have a primitive mitochondrial system and very low expression of cation transporters. This makes it difficult for the metformin to enter the cell, and animal studies have demonstrated embryonic changes observed in vitro are not replicated in vivo. And again, they have done a meta-analysis of over 50,000 infants with congenital anomalies, in which 168 early metformin exposure, concluding that there was no increased risk of congenital anomalies with metformin exposure. And remember, these may be due to the diabetes as such rather than the use of metformin. So clearly there was no any congenital anomalies. But a question again arises, is it because of the glucose or the OAD, which is the toxic agent and that triggers the development of these malformations? And the other advantages, metformin has many other advantages when taken during and after pregnancy, including reduced gestational weight gain, preterm delivery, reducing the insulin requirement and reduction in the operative delivery, and possible reduction in hypertensive disorders and future type 2 diabetes. And benefits are even greater for women with BMI more, and the infant also benefits from reduced rates of macrosomia, hypoglycemia and need for NICU. In some instances where they have severe insulin resistance, of course, metformin therapy during pregnancy may be warranted in addition to insulin, particularly those who refuse insulin. And if you take women with PCOS treated with this metformin throughout pregnancy have a lesser miscarriage rate, and also the metformin does not appear to be teratogenic. And it has shown to be able to significantly cross the placenta with fetal concentration in the range of half that of the maternal. However, it does not stimulate the insulin secretion or release and does not cause hypoglycemia. And metformin enhances insulin action, stimulating the glucose uptake in the liver and other peripheral tissues, and also suppresses the hepatic glucose production. And in MIG trial, if you take metformin, has been proved to be very safe and effective treatment option for women with type 2 DM in pregnancy with or without add-on to insulin. And it has got less maternal weight gain, no maternal hypoglycemia, and cheap and with cheapest oral therapy requiring no vigorous monitoring and frequent hospital admissions, and very good compliance and acceptability. And it also has shown less maternal hypertensive complications, because this also is a feature of insulin resistance, and less risk of neonatal hypoglycemia with less neonatal admissions. And again, you should also remember the contraindication, that is wherever there is placental insufficiency, hypertension, twins, preeclampsia, and growth restriction, they're all we need to avoid this. And very recently, as our mentor said in the morning, the subject expert committee has shown the safety of metformin. Metformin use in pregnancy did not show any adverse effects compared to insulin on long-term outcome in children. And again, the UK, the metformin has found to be safe throughout pregnancy, and this is the first anti-diabetic medication which can be very well used from conception to birth, along with the lesser risk of pregnancy-induced hypertension and preeclampsia. And again, our own endocrinologist from Delhi, he has shown, Sabdaji Bhattacharya, shown about the safety of metformin in pregnancy. He has followed the children up to 11 years. Those who were on insulin, compared them both, insulin and metformin, and found it was not, it was all similar up to 11 years without any untoward effects. And again, during breastfeeding, after 4 hours of feeding, it is not found in the breast milk, and it can be used very well during breastfeeding. Regarding sulfonylureas, using an isolated perfused human placental cotyledons model, Elliott has demonstrated minimal placental transfer of glyburide, but greater transfer of glipizide, particularly the copropamide and tolbutamide, from the maternal to fetal compartments. If diet and exercise do not lead to adequate glycemic control, then insulin should be given. Oral hypoglycemic drugs, particularly sulfonylurea drugs, are contraindicated during pregnancy, because it can stimulate the fatal pancreas, causing hyperinsulinemia, leading to macrosomia, hypoxemia, and all other problems later. And again, another retrospective study on the series of women with type 2 suggested an association between the first trimester sulfonylurea and major congenital malformations. And again, we need to think whether it is because of the drug or the disease as such. And glyburide at present situation, ADA, ACOG, and even our country, it is not approved, it is not FDA approved for treatment of GDM. Regarding alpha glucosidase inhibitors, there is a small study with 6 GDM which has proved to be very useful, and the babies were very normal, and it was bringing down the blood sugar. Another randomized study with the 91 GDM failing diet therapy, this reduced the glucose content or also reduced the HbA1c level, appears to be promising for the treatment of GDM. And if you take those days when we were using only the postprandial abnormality was there, and especially in the first hour it was very high. So when we gave short-acting insulin, it was not coinciding with the absorption of food. So what happened? There was a delayed peak with the short-acting insulin. There was an unwanted hyperglycemia followed by, because of the unwanted action of the insulin, there was a hypo also. The patient tend to take more food, and this became a vicious cycle. We will increase the dose of insulin. All this was happening. So what we did, we added a acarbose to short-acting insulin. So this was delaying the peak of the food, and so that was coinciding with short-acting insulin. And this is called as poor man's analog. That is those days when analogs didn't come. And this has been in category B, same like insulin, and this is not systemically absorbed, and it can be, and it is there is no chances of transplacental passage, and there's no worries about that. And this we have presented in National RSSDI 2002 at Cochin, but we have not used alone, we have used along with insulin. This reduced the dose of insulin, and also it made the short acting coincide with food absorption, and again we have presented as an abstract in 2006 in EASD also. Regarding glitazones, no control data, FDA not approved, and stroglitazone are very well proved to be teratogenic. And DPP-4 inhibitors, of course, it's very good in non-pregnant, whereas in type 2 diabetes, it's very good, but GDM requires more research and it's not approved. Meglitinide, again, it is in the category C in pregnancy and should not be used in pregnancy. And again, the inflammation, oxidative stress, and the gut microbiota participate in the development of the disease of GDM with potentially harmful effects on the health of the maternal fetal biomarkers. So probiotics are also shown to be potential for improving the glycemic control in women with GDM diagnosis. And again, regarding the other drugs, if they are on ARB or AAC or statins, that has to be stopped. And it's better to use low dose aspirin from 12 to 16 week onwards. So the current guidelines recommend only insulin, use of oral drugs to be considered on an individual basis. Though NICE, Australian Diabetes Association, WHO, IDF are all permitted conditional use of this oral drugs, we have emphasized the need for further intensive investigation in order to define the risk and benefits of this line of treatment. Counseling and proper documentation is mandatory if you want to put the patient on oral drugs. If future studies with appropriate sample size and power can clear the complications of oral drugs in pregnancy, they'll be considered as an alternative or add-on therapy in pre-GDM and other diabetes passing through pregnancy. It cannot replace insulin. And if you take the pathogenesis, of course, GDM occurs in women who are insulin resistant with hyperinsulinemia. And this insulin from the mother, though it cannot cross the placenta and reach the fetus, what it can do, it influences the placental action, increasing the growth of it and increasing the angiogenesis, and also causing lipid droplet deposition. And via the GLUT1 and GLUT4 transporters, it is transport the glucose to the fetus and increasing the insulin level in the fetus, causing hyperinsulinemia. Initial all problems is because from the maternal side, and later it is taken over by the fetus, causing all the problems what you see. It has influence on the placenta as well as by causing beta cell excitation. It causes type 2 diabetes later and causing cardiac hypertrophy and cardiovascular problems and increasing the fetal fat, leading to early obesity. And because of impaired hypothalamic development, it has effect on the feeding behavior, and it also increases the growth of the fetus. And so now with all this, rather than talking about the use of oral drugs in GDM, we have gone to the stage of primordial prevention of all the non-communicable diseases. You have heard well in the morning that fetal renal threshold is 110. The fetal pancreas starts secreting insulin at 11th week if the blood sugar is 110, more than 110 or more. So please do just one postprandial at 8th week of pregnancy. If it is between 110 to 119, put them on medical nutrition therapy with metformin 500 half BD till delivery. This will prevent the development of GDM itself and all the non-communicable diseases in future. Preventing fetal hyperinsulinemia is very important because this is irreversible. Once it has started, it will not revert back. So to protect the future generations, it's difficult to have the willpower to control our children for their urge to fast foods, which is available everywhere in the present generation. So let us sow the proper seed in utero without hyperinsulinemia for NCD-free future generation. By this cheap, simple, time-tested drug, metformin started at the right time. Thank you.
Now we invite the questions from the audience, and I request the speakers, previous speakers, to come on to the stage. What is your experience or in the literature, the role of myoinositol in the prevention of gestational diabetes mellitus?
I don't know the mechanism, but still it is very useful in the prevention of GDM.
Okay, but there is no studies. Actually, one study they started at Bangalore. It was stopped in between because the difference they got it was not very appreciable. So they stopped it.
Madam, And to Dr. Nandita, the Tujo is a very good drug, but cannot be controlled the postprandial blood sugar, madam. Because, you escalate the dose, as you rightly said, after 30 you have to think about the other alternatives. So it may be okay for the fasting blood sugar, whether it's U100 or 300. But I don't think so it is going to have any show after the post-breakfast. That is one thing I want to tell you, madam. And
Absolutely. Agreed, sir.
Dr. Bhavdani, madam, I think so. As rightly pointed by all the doyens, including Dr. Seshia, if everyone can try to implicate the primordial prevention by the gynecologists and obstetricians who are the sheet anchor in delivering, and if this message is passed to them, I think so, as rightly said by Professor Sesha, by 2047, we can have free of NCDs. So all these things, as you rightly said, from the primordial. So I think so that will have a lasting effect the future generation.
Yes, it again has to go through from generation, how it has come through transgenerational transmission has occurred through many generations. Again, it has to go through, and as Sir said, by 2047, we may be able to get diabetes-free generation.
Madam, I am trying to say that this information should go to the obstetrician and gynecologist.
So I know you are also talking about this everywhere, and we are talking in the Madam, Dr. Anjalakshi, Madam, she is very well talking.
We are talking in all obstetric forums. Sir is coming. So throughout Tamil Nadu, almost all places, Sir has travelled and he has spoken on the primordial prevention. We are also going to different societies and speaking on that.
The Sir wants to know.
So he wants to spread to the national level. So we are trying to get it to the national level.
We are talking among ourselves, madam. That's all I want to say. No. In every forum, whether it may be a dermatology, pediatrics, geriatrics, obstetrics, again, neurology, psychiatry, this should be deep into our fraternity.
Yes, wherever I meet Sir, he used to say, this is so simple, why can't it be taken everywhere?
Yeah.
Sir, regarding you are talking about the specs, sir, whether it is necessary and mandatory for all my diabetic patients who have crossed 5 years or 7 years, whether I should subject this test for this. Now, where do I play a role? You tell me, sir.
That is, it's a very interesting and important question. Should we make every diabetic patients, especially minimum 5 years duration, should we ask them to go for a compulsory screening with SPECT CT? It definitely helps, but I don't know whether it involves considerable cost involved. In Tamil Nadu government, it is free. We can always make everybody once in a while to come and have a routine SPECT CT, and if the SPECT CT happens to be normal, they can be confident that they will not be having any coronary artery disease. Whereas when a coronary angiogram is normal, the next day also the patient can have a myocardial infarction because we are seeing at a much higher level, whereas when you SPECT CT, we are able to visualize what is happening at the cellular level. Definitely it is a good suggestion. Probably in future it may be a mandatory rule also may come in future. But as of now, as a treating physician, we know that whenever we see somebody with a strong clinical suspicion of coronary artery disease, like for example the clinical conditions I listed out, who has a family history of coronary artery disease, who has been on insulin for a long period of time, who is obese, who has other comorbid conditions where there is a likelihood of coronary artery disease, who has been very irregular and having poor glycemic control. These are the patients who will be much benefited if you are able to do a myocardial perfusion SPECT, and they will definitely be able to appreciate to them with evidence telling that if you don't follow, this is how it's going to happen, and maybe we can optimize the medications so that the quality of life is improved, sir.
Sir, I want to tackle the patient in the initial stage, sir. I don't want the patient, once he gets an ACR more than 30 and IMT is more than 10. I don't want that type of patient. I want to be in the early stages.
It is possible.
When the patient comes to me, before he gets any kind of organ target damage, I don't want to catch at that point. That is not my bread and butter. It becomes all.
That is exactly
my question is, I want to tackle in the very initial stages. That is what I am trying to.
I fully appreciate, sir. That is exactly what I showed all the data, which says that even before the with a strong clinical suspicion is we have to screen the patient, and definitely it helps in the longer run, sir.
Thank you, sir.
Thank you, sir. Thank you for your valuable
This is
comments.
for your information, and Professor Seshia has taken enormous steps. In fact, recently he has met our Honorable Chief Minister of Tamil Nadu, and he has put it that metformin should be used in the pregnancy. And Dr. Anjalakshi and Dr. Pannisalvam, they are following that, and in fact, releasing that to GO is almost in the final stages. Sooner or later, you will get a government order stating metformin can be safely can be prescribed during the pregnancy. If it is so, apart from preaching to the gynecologist, it will go to the entire Tamil Nadu. Automatically, people will start using this. This is for your information.
Sir, metformin can be used, sir. My question is primordial, sir. I'm not. That's
what-
rightly said by
Sir,
Dr.
that's
Seshia.
only in that
After
text.
11th week, there is no use. Any amount, any ton of metformin is not going to work out.
This is in that context only that GO is going to come.
Thank you, sir.
Is there any risk or is there?
Absolutely no risk, absolutely no contraindication for this, even if the patient is having chronic kidney disease with the creatinine. Yes, even if it's a young individual, maybe about 18, 20, 21 years also we can get done. Even if it's a pediatric age group also we can do the screening. And we are going to administer only a tracer quantity, very, very minute, 0.807. This much amount of tracer is what we are going to administer to the patient. There will not be any side effects because of this medication. We are doing routinely in our day-to-day practice, even on newborn babies, in various other test procedures. So it can be safely done. When as a physician, we have a strong clinical suspicion that this patient is likely to have a coronary event or any cardiac ailment, you please refer the patient to us, we will be able to help you out.
So last month was a dark month for Chennai city.
Yes.
We lost 3 super specialists. In the
Absolutely.
medical fraternity itself,
Yes.
we lost all in early 30s and late 30s.
Absolutely, madam.
Before the
Actually,
age of 40.
Yes,
So-
whenever we can always refer anybody to get this done in our hospital. Being in the government hospital is free of cost. Definitely we will take care, madam. Especially patients, people who are in high risk, and especially physicians who are stressed out and who have a strong suspicion that they may have a coronary event. Please send the patient to us, we will do it for them.
Where it is being done, sir?
In Tamil Nadu government multi-super specialty hospital. Omandara multi-super specialty.
Cost of the test?
It is, if the patient is having CM health insurance card, it is free of cost. If the patient is not is really paying for it, it is 7,000 rupees.
Thank you.
Thank you.
So is it available only in your center or it is available elsewhere also?
In Tamil Nadu, almost there are 49 centers in Tamil Nadu, nuclear medicine centers. Only one is ironically in the government, rest all in the private sector. It is available everywhere, and there are almost 570 centers in all over India. It is available everywhere.
Sir, actually what sir wanted to ask is even normal people without any risk factors, if they want to get it done also can do it.
As for the evidence-based medicine is concerned, there are no strict guidelines which says that it should be used for routine clinical screening. But whenever a patient requires, who has a strong clinical suspicion, I will put it this way. When a person is having a strong family history of diabetes, and who is having chest pain, hypertension, diabetes, other comorbidities, when he comes to you, let us not waste time sending the patient to me. And we straight away send to the angiogram and go to do the revascularization procedure, whatever it is. On the other hand, the major chunk of the patients who don't have any family history of diabetes, who are in the younger age group, whom we don't even suspect that there is a possible coronary event, they have a chest pain, and you want to rule out the cardiac causes, please send the patient to us. We will be able to objectively do it, madam.
Any other questions? If there is no question, we will wind up this. Thank you.
Thank you for the emphasis.